But this is a very interesting study actually done with Mr. Matt Dawson and his team in North Cumbria. And it's comparing two fixation techniques of double-level knee osteotomy, hybrid fixation versus conventional fixation. And we are asking the question, are we improving the accuracy? Throughout the whole day, you've seen that there has been rapid evolution of knee osteotomy throughout the years, especially in the last 2 decades. Several adjuncts have been introduced throughout the osteotomy process with the prime target of improving the correction accuracy. These adjuncts either addressed the preoperative stage or the intraoperative stage. But despite all these adjuncts, correction errors and outliers are still being repeatedly reported. And this is the scenario in a single-level knee osteotomy, let alone double-level knee osteotomy, which is gaining popularity, as you've been hearing throughout the day, due to its merits in maintaining a physiologic joint line orientation. But it's a complex procedure, and accuracy here is of the essence. And that's the main axis where the main study revolves about. So this study compared the 2 fixation techniques, hybrid fixation, where we fixed the femoral osteotomy with the plate, and the tibial osteotomy was fixed with an intramedullary magnetic extendable nail, and the conventional fixation, where both the femoral and the tibial osteotomy were fixed with plates. The primary outcomes, we looked at the correction accuracy in the coronal plane, and the secondary outcomes, we looked at the correction outliers, and we looked at the variety of clinical outcomes as well, complications and satisfaction. And our hypothesis was that there was no difference, there won't be a difference between the hybrid fixation versus the conventional fixation. So it's from a single surgeon osteotomy database. These are Mr. Matt Dawson osteotomy database. We identified 52 double-level knee osteotomy cases. After exclusion of all the irrelevant cases, we ended up with 24 cases of double-level knee osteotomy for various knees. That's a combination of medial opening wedge high tibial osteotomy and a lateral closing wedge distal femoral osteotomy. So 12 in the hybrid group and 12 in the conventional group, which makes it a fair comparison. So in the preoperative stage, in the planning stage, planning was identical for all patients in both groups. So digital planning software, Miniachi's method for the medial opening wedge high tibial osteotomy, and a reverse Miniachi's method for the distal femoral osteotomy. And Mikulicz was set at 55% of the medial tibial plateau with 10% tolerance on either direction. And intraoperatively, the execution was similar as well in both groups, biplanar osteotomy for the tibia and the femur as well. So the difference is that in the nail group, where the tibia was fixed with the intramedullary extendable nail, so the surgeon would initially create a track for the nail, then insert the nail and pre-drill the anteroposterior proximal locking screw, then remove the nail and execute the osteotomy. And the beauty of the nail is that intraoperatively, the surgeon would perform dynamic rehearsal of the opening wedge osteotomy by slowly and incrementally opening the gap. And he would do that to above 50% of the targeted correction. And this is mainly done to avoid any potentially excessive harmful stresses on the hinge or the screws in the postoperative extraction process. This is a fluoroscopic image of the nail. You can see that the magnet of the nail can be easily identified under fluoroscopy. So the surgeon would put a couple of stables so that he can locate the magnet for the patient, make it easy for the patient to identify where the magnet of the nail is. Because post-operatively, the patient would locate this remote control over the magnet of the nail, and with a specific movement, either clockwise or anti-clockwise, they can lengthen or shorten the nail, and that's why doing the correction. Just before I delve into the results, there are 2 concepts from this study I want to make it very clear, because there is a lot of discrepancies in the publications, what's accuracy and what's outliers. So the correction accuracy in this study is the absolute deviation of the achieved correction from the planned correction, and the outliers were those cases with greater than 10% difference from the planned correction. There was no significant difference in the demographics of both groups, neither in the age nor in the BMI. But both groups, there was significantly achieved correction in the coronal plane, about 14 degrees of correction in the coronal plane, you can see from the mechanical tibio-femoral angle. And the Mikulicz was significantly improved as well. There is an average correction of Mikulicz about 64% in the nail plate group and about 57% in the double plate group. This is an example of a case corrected in the conventional group with double plating of the tibia and the femur. So from a preoperative Mikulicz of -15 on the left to postoperative Mikulicz 58%. And this is an example of a case that's corrected with the nail in the nail plate group from a preoperative Mikulicz of -21 to postoperative Mikulicz of 60%. So both procedures are great and they're doing a significant correction. but it's the point when it comes to the accuracy, because at 3 weeks post-operatively, we get a long leg standing radiographs for all patients. And in the conventional fixation group, if you got a specific correction, you evaluate the Mikulicks, that's it, you can't do anything for the correction. But in the nail plate group, at 3 weeks down the line, you still can fine-tune the correction so that you can achieve better accuracy. And this is actually what happened in our study. So in the nail plate group, the accuracy in the nail plate group was superior at 3.4% compared to 7.1% in the double plate group. We didn't have any outliers in the nail plate group compared to 16.7% outliers in the double plate group. Clinically, all patients significantly improved in both groups by the simple knee valley and vast pain scores at 2 and 5 years, and postoperative satisfaction was over 80%. Complications were not significant in either group. So the conclusion, superior correction accuracy was achieved in the nail plate group when compared to the double plate group, and no outliers were achieved or were observed in the nail plate group when compared to the double plate group. The nail gives you the advantage or offers the advantage of fine-tuning the correction in the post-operative stage. This is an advantage that's not present in the conventional plating, and we believe that it could be a potential research template for future research implants that's targeting the post-operative stage or targeting improving the accuracy in the post-operative stage. Thank you.